Hi, I'm Ginny Dyche. Welcome to Aspen Valley Hospital's Medicine in the Mountains. Today I'd like to introduce Michelle Muething. Welcome, Michelle. First time on the show here today. Probably some of you know Michelle. She is the executive director at the Hope Center, and she's a licensed counselor, professional counselor. Yes. So I just want to start by asking you to tell us a little bit about you and your background. What's a licensed professional counselor?
Licensed professional
It sounds
counselor. It sounds good. Every state has a different license for clinical psychology individuals who are trained and experienced in diagnostics, assessment and treatment, things of that nature. So in the state of Colorado, my clinical psychology degree allows me to have an LPC, which is a licensed professional counselor. Different licenses, different states, different individuals. But I've now been in the Valley 4 years, so I have a new way to call it home. It is definitely home.
And where are you from?
We moved here from Indianapolis, where I had spent 13 years teaching at Indiana University School of Medicine. I was a crisis clinician in an emergency room doing a lot of suicide assessments, worked with a lot of patients with bipolar disorder and schizophrenia. Inner city hospital, very busy. I had a private practice for a little while. I was a corporate compliance officer at an addictions facility for 4 years. So moving here was definitely a slower pace. And we were really excited about it, but jumping into the Hope Center has definitely been just as busy.
Well, and our topic today, of course, relates to mental health issues and suicide in particular, because our community has really just been jolted by recent incidents here and tragedies, really, just tragedies. So your background certainly brings you well prepared for what you're dealing with, what we as a community are dealing with. But before we talk about that, just give us a little more information about the Hope Center.
The Hope Center is also almost 4 years old. It actually opened not too long after I moved here, and I had the great fortune of being part of that. But the Hope Center is a crisis and referral agency. We are not a community-based mental health center where we are all things to all people. We are not funded by the state or the government.
And so you're not doing marriage counseling?
We do. We've expanded into that a little bit. What we don't do is urine drug screens. We don't sign people up for Medicaid. We specialize in crisis. That is first and foremost our specialty. So we have 4 arms. We do information and referral. So about 24% of our phone calls are basic questions and information. Can I have a referral to a marriage counselor? The second arm of what we do is our crisis, and our crisis is mobile. The crisis team goes out to the communities. So they'll go to schools or to physicians' offices. They'll go to homes. I have a clinician right now sitting in a living room. So we go to the person and meet them where they are. Part of that crisis piece in being mobile is we fill a gap being in a very rural resort area where we don't have a continuum of care. And so in our crisis arm is what we call our virtual intensive outpatient program, and it's an alternative to inpatient hospitalization. I'll talk more about that later, I guess. The third arm of what we do is our education and outreach. We do a lot of suicide prevention classes. We also do crisis prevention and de-escalation classes. We do psych emergency classes for law enforcement, first responders, EMS, fire, and even in the hospitals. And then we also do just education based on a topic that someone might know or might need. They may call and say, do you have anyone who can talk about eating disorders? We would like that to be a topic for our students. And if it's not something that someone within our agency has an expertise in, then we utilize our connection with the university in Denver, where our medical director resides, and we get someone to come in. So education and outreach is our third arm. We feel like that's huge in reducing stigma and increasing awareness. And then the fourth arm is our community collaborations. And we formed that in our second year when we were really approached by a lot of different entities in the community to say, can you bring mental health expertise to RAFTA, YRC, Aspen Valley Hospital, whatever the case may be. And we formulated several wonderful partnerships. Basalt Schools, Roaring Fork High School, Youth Recovery Center in Valley View Hospital, Aspen Valley Hospital in general, Roaring Fork Neurology in Basalt. Lots of different entities that we collaborate with, SKICO, just to be able to bring our crisis experience and expertise to that area. That's the Hope Center in a nutshell.
So here we are in this beautiful community.
Beautiful.
Small town, which I always think of small town, easier to make connections with people and develop support systems. Probably a quality of life that you don't find in big cities or many even smaller communities across the country. We have great resources, such as the Hope Center, yet we have this suicide rate that far exceeds the national average. How do we as a community make sense out of that?
You know, I don't know that you can. In the last month, we have been inundated with phone calls and questions, and people want answers. They want to know what to do. And one of the questions I was asked that was a pretty poignant question was, are we really that different than other places in the country? And to be honest, the answer is yes and no. We're different in the fact that we're small, and rather than having 6 degrees of separation with people, there's maybe 1. So when there's a suicide in Aspen, you will know someone who knew that person, and it's probably through one person if you didn't know them yourself. So being small, you have a much higher opportunity to know these individuals versus a big city like Chicago where you get lost. The way that we're different and why our suicide rate is so high is suicide rates are calculated based on per capita populations. So for 2012, for instance, or 2013, there were 6 suicides in Aspen, I believe, the total for the year, and there were 14 in Garfield County. So even though Garfield County had more than we had, because per capita we have fewer year-round residents, we were ranked higher in the state. So it is in our faces more. In a big city like Chicago, a suicide would possibly get a line in the obituary section, whereas here it's everywhere. So it's much more prevalent in day-to-day living. How do we make sense of it? I don't know that we do, but I think the best part about living in such a small community is the community comes together in such a strong, profound way to say we want our community to be better, we want our community to change, we want our community to be healthier in every way, including mental health. Whereas again, in a big city, some of that kind of gets lost.
Okay. So you're involved in crisis intervention. You're a crisis clinician, as are a number of your staff. So tell me about the day in the life of a crisis clinician.
You know, I think the best way to think of it is if you think about any of those movies you've seen where the fire alarm goes off in the firehouse and all the firefighters go sliding down the pole and take off. They could be sitting having dinner and the bell goes off and off they go. We are exactly the same. We have an office that we all meet in the morning, and when a call comes in, we mobilize and we're out the door. It can be a day where it's very quiet. We like those days because when we're bored or when we don't have work to do.
This is good.
This is good. No one's in pain today. No one's suffering today. It's not right there. But being a 24-hour crisis agency, the clinicians answer the phones, and they are available 24/7. So at 8 o'clock at night, you're going to get a clinician on the phone. At 2 o'clock in the afternoon, if they say we have a suicidal person on the phone in Blue Lake, we're going to get on the phone with them, we're going to figure out what's going on, and we'll probably end up at their house or they'll end up at our office. So a crisis clinician's job, first and foremost, is not to dive into somebody's past. We don't want you to divulge all these skeletons. We want to know the here and now. What is going on right now that brought you to this place, and what do we need to do to stabilize it? So we are very much here and now people, and we go backwards when needed. But we need to know what your support system is, what your history is of suicide attempts or mental health treatment, and then what is going to make the difference going forward. So from the first second we lay eyes on someone and start with our introduction, we're immediately trying to formulate, what do we need to do to make this person's situation okay? How do we be the calm in the storm? And how do we mobilize the friends and family in this person's life to support them?
Yeah. So it makes me think of the person who would come to the hospital with chest pain.
Yeah.
And the doctor's first job is not to look at what was their diet like.
Right.
Did they exercise or not?
Exactly.
What was their family history at that moment in time?
Right.
It's to evaluate what's going on right then and what actions need to be taken, really to save a life.
Absolutely.
And then the next step is let's start looking at how the person got there and how we're going to move forward.
Right. Right.
So.
If their blood pressure is dropping every time they stand up, or their heart rate is escalating when they do something, how do you stabilize that in order to get them moving again? And that's exactly what we do. We actually, crisis in mental health is considered like the ER of medicine. You know, a family physician doesn't respond to a patient that shows up in the ER at 10 o'clock. It's your ER physicians who are available. And the family physician can be called and be brought in, but we consider ourselves the same sort of thing. We are the ER of mental health, so to speak.
And you are available to Aspen Valley Hospital.
We are.
24/7.
We are.
I just had a question. I know you've been getting a lot of calls from reporters and various people we have at the hospital too.
Yes.
And I just spoke with someone yesterday who said, so what happens when someone comes into the emergency room and they're in crisis?
Right.
What happens? And we were kind of walking through the process, and I said, well, we're going to call the Hope Center or Mind Springs Health.
Correct.
And we're going to, because they are the mental health professionals in our community. And he said, you're going to call them at 2 o'clock in the morning on a Sunday night? And I said, yeah. And he said, and they're going to be available?
Yeah.
And I said, yeah.
Yeah.
That's how it works.
That's how it works. We all have our silos that we're trained in and that we work in, and we don't expect people in other areas to know how to interface with a suicidal person any more than I would expect a law enforcement officer to think that I know every aspect of the law showing up on the scene of a car accident.
Right.
You know, everyone has their own areas, and if you can mesh them together, the outcome can only be positive.
Okay, so the crisis intervention then, you said it may be on the phone, it may be going to their home,
Correct.
it may be coming to you. But what does that really look like?
So in the world of mental health, one of the biggest things for us is when we're doing an assessment, we're getting one story. And as we all know in life, there are two sides to every story, and most often 3 or 4. So for us, our goal in trying to help make good recommendations with someone is to get information from them, but to hope that they either have someone with them or that we can call in a time of higher crisis, so we can get a more rounded picture and the pieces to the puzzle fit. Crisis clinicians are not magicians. We're not miracle workers. We don't have a wand. We can wait. We use that hypothetically as a question sometimes. If we could give you a magic wand and change something, what would you change in your life? But an hour in a therapy office can be very profound, but when a person leaves that, if they go home and the thing that's bothering them the most, say finances, they go home and grab their mail and they open a bill that says, you know, here's a bankruptcy notice. Suddenly that hour of therapy is put to the test. Can I utilize the skills that I learned in therapy to get me through this crisis? And sometimes you can't. So when someone's in a high-risk state and very fragile and very vulnerable and deep into depression, our goal in a crisis session is to formulate a safety net, and that safety net includes their friends and family. And so the tighter we can pull those friends and family together, the higher the chance that person has to get through. And when I say we pull them together, I mentioned the VIOP. That's part of our crisis team, and it's our program that we implemented to keep people out of the hospital. If we implement this virtual intensive outpatient program, it is comprised of a Hope Center clinician, a private practitioner in the community, and then at least another point of contact in that person's life, if not 2 or 3, if possible. So every day that person wakes up and they have a call that they have to make to us. If they don't call us, we call them. They then see us at some point during the day. They see the private practitioner every day. They see our case manager every day. And we have that friend, family, roommate, whoever is with them, coworker, check in with them every day, and then they check in with us. So this person, I call it like human bubble wrap. They are never out of arm's reach of somebody that can help them. And they call us to check in at night and say, here's my day, here's how I rate my depression and my anxiety. I'm going to bed, I'll talk to you in the morning. So they're wrapped from morning to night with any possible care, support, and treatment that they need. And I think that's what makes the difference, is for people to know that they're not alone and they're not just supported by one person.
So you really increase the likelihood that that person with suicidal thoughts is going to get through the day, is going to manage whatever obstacles they have to face during the day. That it's much harder for them to just throw in the towel and say, I'm done. Because there's a whole lot of people that are involved in what's going on with them over the course of the day.
You know, over the course of our time, we've had 77 people go through this program. Some are really funny. They're like, I don't need a babysitter. And I said, no, I know that. Just humor us, you know. Or, but what's really funny is when they have to call at 9 a.m., the ones that seem most resistant on the front end are the ones that at 9 on the nose, their phone call comes in, hi, I'm calling to do my morning check-in. Or when we call, they're happy to hear from us, and we'll say, you know, we only want to check in for a few minutes. This is not a therapy session, but we want to hear your voice. We want to see how you slept or how your day went. They'll keep us on the phone for 30 minutes. So you very quickly come to realize people are so happy to have that support. And more than anything, I think they see that when there are 3, 4, 5 people putting effort into their well-being, they start to kick in too and realize, if they're going to help me through this, I'm going to help myself. And that's success to us, is to see that change in people over time. So that's what we do when we go to an ER. That's our first assessment job, is to figure out, where does this person fall in risk level. So that's our primary goal.
So you know that as a community, because of that small town feel, and we all care about people here, whether we know them or not. Well, we want you to save every life.
Of course.
You know that. We want you to save every life. Not every life is saved.
No.
Maybe those people didn't find their way to a mental health professional, whether it's the Hope Center or some other counselor. They didn't find their way. Maybe they did find their way. And their life still wasn't saved. So I just want to talk about that a little bit, and it's kind of hard to talk about, because I think we would like to believe that if people reach out to that person, if that person has a support system and people they can talk to and work things through with, and people that care about them, that's all it takes. But clearly that's not the case sometimes.
No.
It seems like there are people who have really made a decision to take their life. And it almost feels like that's what's going to happen. I mean,
it is hard to talk about, because you're right. Our belief, and funny enough, we truly believe that everyone can be saved. I mean, I think that's the belief that everyone goes into this field wanting to believe. And what's interesting is some of the individuals that sit in front of us with their stories, they're in such a deep state of depression that we sit and listen to their story and think, these problems are absolutely surmountable. You just need the right support. They're not life-ending problems. But when someone is in such a state, sometimes they don't see it that way. And then there are those individuals who, like you said, for one reason or another, they've just made up their mind. And I run a group called a Lifeline group, and there are 19 individuals that have come to our circle. Started with 4. And it's sad that there's 19 individuals who have lost someone to suicide, and that doesn't even begin to look at the iceberg tip of who's really out there. But those are who've come through our doors, and they all have different reasonings and that they've come to, and they've all got their story as to why, because we will never have an answer as to why. The person's no longer here. And funny enough, people will say, well, did they leave a note to explain why? And half the women who have a note say, but the note doesn't tell me anything. The note doesn't give me any explanation. Yes, I have a note. But sometimes I call it kind of the mask. Sometimes people get so good at wearing a mask and being something that they're not, for whatever reason, fill in the blank. But they become so good at hiding their pain and being something that they aren't, that when they're confronted with pulling that mask off, they don't know who they are. They've lost sight of who they have been, and they only know the mask or the facade that they have been. And I find that those are people who can get stuck in that dissonance of here's who the world sees me as and here's who I really am, and I don't even know that I can define who I really am. And there are people who have made decisions to end their life, and it has been very calculated, very planned out. The hours before what they've done, people have encountered them and come across their path, and they've been laughing and jovial and
appeared to be perfectly fine.
And part of that is, you'll hear people, experts in the field of suicide, who will say part of that is the relief they feel that they've made a decision. And they feel at ease with the fact that everything's about to be over. So sometimes that happiness can have a secondary meaning. So when we tell people what to look for, it's hard to be exact, and there's no exact science and cookbook that we can open to say, here's the suicidal person and here's what you do.
So I'm guessing that there are a fair number of people that commit suicide that have an underlying mental health
Absolutely.
Issues,
Sure.
the bipolar disease or schizophrenia,
Right.
or substance abuse issues. Is that in
Absolutely.
fact the case?
Suicide is highly correlated with substance abuse. In fact, many, many, many suicides also have substance abuse involved. Eating disorders are highly correlated with suicide, as well as bipolar disorder, depression, and schizophrenia. So all of your major mental illnesses absolutely are tied to possible suicide.
Have we, as a profession, as a medical profession, as a mental health profession, as a society, have we failed in the area of mental health?
No, people have asked me that a lot in this month. Just, has the community failed? Have we failed our fellow community member? Have we failed our neighbor? Have we failed our friends? I don't bring the word failure into this equation at all. And to me, it's uplifting, because I can't tell you, at least half a dozen times in the course of a week, someone will call the Hope Center and say, I saw your flyer, or I took your course on suicide prevention, or a friend of mine told me that you do crisis. So the community's talking. The community is aware. The community calls us. We get probably I would say a good third to a half of our phone calls are people concerned about someone else. They're not even calling about themselves. So the community has absolutely succeeded in looking out and being aware for the people they care about. It's looking at, and I've been asked, what's missing then? And to be honest, we are really stopping and dissecting crisis and saying, what is missing? And truly the piece that we think is missing is our tight-knit way of pulling in that person's life and the people in their life to help us with what we know and how we can help that person. So have we failed? Absolutely not. Can we do better? Absolutely. The world of mental health, the field of mental health, the system of mental health is definitely a broken system. It is a system with too many people, not enough places to go, too many inpatient needs, not enough inpatient beds, not enough insurance coverage, not enough practitioners, too high of fees. So it's definitely a broken system across the country, but not just here. And this is our small way of trying to say our specialty is crisis. Can we hone in and help people in a time of crisis?
So if there was one thing that you could say to our viewers about suicide prevention, what would it be? Never
take anything lightly. If your gut tells you something's not right, you're not okay, go with your gut and don't give up. Don't leave their side. If they agree to go to a crisis appointment, go with them. Don't leave the room or don't leave the lobby or don't leave the building. Go with them and know what happens afterward.
Be obnoxious if you have to be.
We say that. Be that Chinese water torture. We tell people that all the time. Be relentless because they will be thankful in the end. So don't give up. And again, if your gut says something's not right, you hear people a lot will say, you know, they had a substance use issue. I got tired of dealing with it. It's so hard to deal with. Let us help you. Let us be that support for you too.
Michelle, thank you so much for being here.
Thank you for having me.
I'm Ginny Dyche, and this is Aspen Valley Hospital's Medicine in the Mountains. I've been speaking with Michelle Muething of the Hope Center. Great resource for our community. Use them if you need to. Thanks for joining us. Bye-bye.